Welcome to 106 Life Factors, an educational interview series where guests explore questions about their perceptions of life and the factors that affect all of us. We're living in a very complex world and we want to find out about people's inspiration, motivation, and drive, especially based on the type of work they do and the guiding forces that help them get through life. 106 now invites Dr. Sandy Ramirez Sanchez. She is a licensed social worker with a Doctor of Social Work degree, with over 10 years of direct social work practice with inner city families. Dr. Ramirez works in the emergency department and weight management program at Nemours DuPont Hospital for Children in Wilmington, Delaware. Dr. Ramirez have also done research on health literacy with the Latinx community, and she's also interested in macro policy changes to address health disparities and mental health needs of the Latinx communities. Welcome, Dr. Ramirez.
Thank you.
Now, this it's very interesting, your background and the type of work that you do. Tell us more about the inner city families that you see in the emergency room, based on the racial and ethnic makeup of these individuals and families, and what are some of the needs that they are addressing?
Sure. So I work in a pediatric department, so I can see anywhere from a newborn all the way to about age 21. Around that age and older, we end up transferring to an adult facility. But what we're seeing is a lot of families from immigrant communities, a lot of newly arrived families from Guatemala, a lot of families from El Salvador. We have families from different parts of Mexico and Latin America. We have a high concentration of African American families in Delaware in the Wilmington area. So you see a lot of families in that mixture. And we also serve a lot of families from New Jersey, Maryland, and southern parts of Pennsylvania that come down because we're so close to the Pennsylvania, Maryland, and Jersey border.
And in terms of the needs that you're addressing, especially now during this pandemic, tell us some of the things that these children or and family members, some of the things that they are experiencing when they come into your emergency room.
Yeah. So we're definitely seeing, especially, as of last year in 2020, with so many different changes to how we live and socialize, there was initially a decline in the number of people seeking care in emergency departments because, there was a fear of getting COVID by being in emergency rooms. So initially there was a decline and the census was pretty low and some people were delaying care. So we ended up then having a significant surge later on in the pandemic, especially around the summer and fall months, with more acute mental health needs, children who had structured day programs through autism programs who now all of a sudden were at home all day and didn't have the routine, were having behavioral outbursts of aggression and things like that. A lot of children with anxiety, depression symptoms that were getting harder for them to manage, a lot of psychosomatic patients that would come in with chest pain, palpitations, and they had just had their first panic attack and didn't realize it. And a lot of kids who unfortunately had attempted suicide or were contemplating suicide. The other unfortunate side of the pandemic was an increase in the number of children we saw come through the emergency department for child abuse concerns, physical abuse particularly, and those tended to be a little bit more serious in nature,
Mhm.
because the typical maybe safety nets like school that maybe would keep an eye out for kids or would be an outlet for that child were no longer in place. So by the time they ended up in our emergency department, they had more significant findings.
And the you mentioned psychosomatic symptoms that many are coming in with, and when they learn that these are not severe enough for them to be admitted, say for example, in a mental setting or in on the medical floor, what are some of the strategies or suggestions that are given to family to cope with the experiences that they're having, especially brought on by this pandemic?
Yeah. So definitely one of the that we wanted to make sure is that the parent and the child or the caregiver was aware that the child is healthy. Because I think it was, at least for the parent, a relief to know that the child didn't all of a sudden have a cardiac condition, or didn't. Some children would think they might have a brain tumor. We've been asked a couple of times, do I have a brain tumor? Is there something wrong with my body, my heart? Is there something wrong with my stomach? And that's why it hurts. So assuring the child that they were healthy, that their body was healthy, was a good way to then lead into, now what do we do about some anxiety that you're having, some depression symptoms that you're having. I mean, I want to back up for a second and just, everybody that comes to that emergency department, regardless of why they're there, as long as they're 12 years of age and older, we screen for suicide. And we also screen for behavioral health concerns. We screen for 5 domains: depression symptoms, lifetime history of suicide, current suicidality, trauma that includes human trafficking concerns, and substance abuse, because we all know how all of these things are very much related. So, the child could be there for, um, I don't know, injury. They twisted their ankle and they could be there for that. But
Mhm.
if any concerns come up that they might have some symptoms of depression that should be looked into, or they were sexually abused as a child and never disclosed it before, we are called to address upon those issues, because we know how much, adverse childhood experiences, ACEs, can really impact a child's health beyond just their body health, but their emotional and psychological health.
Mhm. So, parents are, do you find that repeated cases where one family may show up at your emergency room, you assess based on those 5 domains, and you find that it could be based on psychosomatic symptoms, and more likely in the lower level of concerns? Do you find that they return probably with increased symptoms based on what they thought are actual um, emergency issues?
So, as you say, return. Um, because I'm in the emergency room through Friday, I'm recalling a particular case of a child that I clearly remember seeing around November of 2019, that ended up back, I want to say about 6 months later, with a suicide attempt. And
Mhm.
we had, you know, flagged concerns 6 months prior, and really um, discharged with many recommendations, and really pushing for things not to further decompensate. Not that they always do, but that
Mhm.
they can. And
Mhm.
then what do we do more preventative nature? And I remember walking back into that room and talking to that mother who said to me, "You remember me?" And I said, "Yes, I remember you." And she's like, "Here we are." And I said,
Mhm.
"Yes, here we are. And then let's figure out how to never be here again."
Again. Mhm.
Because, research that once you attempt suicide once,
Mhm.
you're at a higher rate of attempting again. And when we're able to have those open and honest conversations with families,
Mhm.
which aren't, they're not happy about it. We're sad to see them back, but we still have an opportunity to prevent it from happening again. And what can we do moving forward? Um, I would never make a family feel guilty or say, see, you didn't follow our recommendations that we made, we
Mhm.
wouldn't be here. I think that would be completely unethical to do to a family. I think what we need to do is, we're here, and how can we not be here again? Let's work towards what do we need to do now and moving forward with it.
So,
It's not, it doesn't happen often, but it doesn't happen often, thankfully. But, do we see sometimes kids get worse?
mhm.
Yeah, we do. Their abdominal pain could get worse to the point that now they don't eat and they're dehydrated and they need to be hospitalized because of it, 'cause they're so dehydrated. Or, do we see kids that, because we also have a lot of eating disorders
Mhm.
coming in that need to be medically stabilized, and there's so many things that you see through an emergency department, but with that comes opportunity, and opportunity to really engage and try to at least, um, even though we're not providing a direct intervention, a direct
Mhm.
mental health intervention. We're not starting therapy, for
Mhm.
example. We do have an opportunity to guide a family as to what they should be doing next, so that we can stabilize the child and get them in a better place.
So they're coming in for what they consider to be crisis, and then you direct them to the appropriate services within the community or within extensions of the hospital that you saw it best. You mentioned previously about some of the onset as a result of the pandemic, and families have to be still need to be referred to community agencies for help. Do you find that based on the communities that you serve, that they are offering virtual services as well? So you have a family, your children who are expected to attend school virtually, they're expected to attend therapy virtually. Everything has to be done virtually. Um, can you share a little about that and what you're dealing with in terms of the families and the referral resources available to them during this time?
I think that mental health system has never really been has never really adequately addressed the diverse needs in the pediatric population. But I think what the pandemic did was blatantly show where those
Mm,
gaping holes are.
mhm,
What the school system has done for these kids in terms of a safe place where they can get a breakfast in the morning, where they can get access to teachers, but access also to guidance counselors, where they get to do extracurricular activities, where they get to socialize with friends at lunchtime and maybe after school with their activities and clubs and sports and different hobbies and interests. When that was taken from this population, this
mhm,
school age population, and they no longer had those, that to a certain extent was something that kept a lot of kids from even entering the mental health system or needing a therapist or needing any other things, because they had outlets, they had a close friend, they had interaction, human interaction, face-to-face interaction, and activities like, prom and dances and things like that. But once that was taken and
mhm,
there's not enough therapists and still virtual, I think it showed just the giant holes in this system that are not adequate, because there's not enough therapists, not enough that are trained to work with younger children or maybe adolescents. Um, a lot of therapists that are unfortunately scared if a child brings up suicide, whether that's because of liability or just being uncomfortable with having that conversation. And the other end of it is, um, some providers, some therapists that won't even ask children if they're suicidal. And that's a conversation that if you choose to be a therapist, you should be competent in, and you should be able to have those conversations, those age appropriate conversations, not just with that patient, but with the family in case they any red flags or have any concerns. So sometimes we end up having kids sent to our emergency department because they happen to express that they had a suicidal thought. And that thought isn't explored. That thought is immediately sent to the emergency room for us to explore and clear. And I use clear because you don't clear a child, you make sure that they're safe, and you safety plan if you need to, and you make sure they're receiving the level of care that should be at that point, for depending on what their needs are.
So it appears that your hands, there's a lot going on,
Oh my
with the type of work
God.
that you do, Sandy. And you mentioned the gaping hole that you mentioned in terms of disparities, the population that you serve, that they experience. But I'm also interested in more. Can you speak more on this, being cleared or medically cleared or mentally cleared from, requiring, a next, a type of service, maybe, admission somewhere. Do you believe that some of these, mental health service providers, or it could even be medical providers, are, kind of shifting this, or have this concern about liability, and, taking precautions to say that the emergency room is a safe haven then, versus doing the actual job, where you're saying that times you're not doing suicide and risk assessment, or exploring a client's response that they're feeling suicidal. What can you share about liability concerns in terms of being clear or medically clear, and this gaping hole in terms of the disparities, and therapists basically, or even medical service, providers not doing their jobs?
I mean, even prior to, like, a lot of schools, if a school guidance counselor talked to a child and the child said, I cut last night, or the child said, yeah, I've thought of killing myself, the conversation would usually end right there. And sometimes they would call their crisis department and say, hey, I need you to come out here and see this child.
Mhm.
But many times they would show up in the emergency department because the school would call the parent and say, your child said they're cutting. I need you to take them to the emergency department and have them cleared. They cannot return to school until they're cleared. And it would be a dramatic it was almost like, we're not going to be liable as a school system if anything happens to this child. We're
Mhm.
going to send you to the emergency department. The emergency department talk to you, and they can decide what to do with you. And then ultimately, if they send you home and say you're fine to be home, it's on them because they sent you home. Sometimes they would look to the crisis department to do that, but the crisis department, depending on where you live,
Mhm.
and kind of like how the department operates, they might come and see you, or they might direct you to the emergency department as well. It kind of depends on where you live. Um, and it always seemed to be like, let's not make a decision about this. But I think some of the school districts did that because they don't necessarily have somebody that would be able to do a risk assessment and kind of be able to close the loop in regards to, is this imminent risk that the child needs to go to the emergency department, or is it something that we need to talk to the parents about getting outpatient therapy or partial therapy? And I don't necessarily know if that falls within the scope of school guidance counselors to do,
Mhm.
or maybe the policies of the school, that they're not to do that, that they are to now call crisis department, or they're to direct them immediately to the emergency department. Um, and then I think that when we're talking about, like, these gaping holes
Mhm.
in the outpatient mental health world, because partial program services and inpatient sites have their own issues. It's not a perfect system all around. um, you definitely do see that people who don't have insurance have a lot more difficult time getting a therapist, but also you realize that, therapy is just a tiny component of what keeps a child, an adult, healthy and happy, psychologically happy and
Mhm.
stable. A lot of the things that we do as humans, birthday parties, activities, a lot of these things, when they're removed and they're not an option, you know, can be so damaging psychologically to so many, can really make anxiety and certain and depression and other mental health symptoms so much more worse that they become unmanageable for many patients.
So let's look at this. Let me call it the what should be the corridor of services. You mentioned a child is at home, the child cuts, the child get to school, share with the teacher or with a peer that, I cut last night. It reaches the ears of the principal or possibly the school social worker. One of the things that you said, well, maybe the school district doesn't have anyone to do the risk assessment. I thought there's provisions for social workers, like a child study team, social worker, psychiatrist, nurses, within their nursing office. All those individuals are part of a team that would work holistically with this with a student within the school district, and then from there gather enough information, reach out to collaterals to get enough information in order to help this child before they're shipped out to the off to the emergency room, especially the fact that it's afterwards that this child is sharing this information. So the child is in a safe space at school. why do you
Mhm.
why do you believe that the school system, as you said, that maybe they're told not to, is as if a school social worker should be conducting clinical assessments or actually doing simply administrative job. Do you agree with that?
I think every district is so different. I
Mm-hmm,
mean, there's some social workers out there who have the backing of that school system to do, you know, a risk assessment and to really make clinical recommendations on what that child needs. And depending upon the leadership, I really feel that ultimately it depends on the leadership, the
mm-hmm,
policies that are in place, and how how do schools manage suicidality? How do schools manage um, negative coping skills like cutting? Because
mm-hmm,
somebody cuts doesn't mean they want to die. It
mm-hmm.
doesn't mean they're suicidal. It doesn't mean that
Exactly.
we need to seek inpatient hospitalization for them, which isn't also a way to like cover things. I mean, sending somebody inpatient psychiatrically can be very traumatizing for a child. So, I mean, those types of decisions have to be made with the uttermost consideration for what is the best thing with the circumstance that we have going on with this child. It's always about getting them what they need in the least restrictive setting. Because again, inpatient psychiatric treatment is not going to be the right solution for every child. And I think that depending upon the policies and the leadership in place for many school districts, that really dictates how much work they want to do with kids in that sense when it comes to their mental health needs,
Mm-hmm,
whether that's establishing a good relationship with their crisis department and trusting their assessments, or if they completely bypass their crisis department and just go straight to, like, you need to go to the emergency department to get cleared, or that idea that the child is cleared to go back to school. Again, I attribute all of that to really the policies and the practices that the school district adapts based on who's in the leadership position to really make those calls.
Yes, so now we're talking leadership. We're talking about trying to avoid being liable. We're talking about, you know, not, you know, fully assessing a child's need, and shipping the child off into a setting that may even further the trauma. Those are very good, important points that you're making. And it's so much areas that we could look right into. We're still at question number one, because there's so much that you're sharing, Sandy, that that you know needs to be explored. And so I mentioned that corridor of services that this child may experience, with just by saying, you know, having this negative coping skills that you mentioned, the approach that this child may take to resolve whatever feelings that they're having. And so they get to the emergency room, and you get them cleared, for example, and then they're right back to a system that has failed them in the first place. So it becomes this cycle. With all of this work that you do, and this abundance of, you know, traumatizing situations that you may come across, trauma for the children themselves, for the family, and even for yourself as a medical as a mental practitioner, to be working that setting. Where do you find your sense of meaning in your life? What is your sense of meaning? Do you get feedback from your patients? Do you get feedback from you know, the client's family, your peers, and so on, to understand the work that you're doing, and what it means to be, you know, to inspire others or yourself?
I think that meaning in my comes from the ability to answer the question as to that a lot of patients have and a lot of parents have when they come in is what is going on, and why is this happening. And I think that when, you know, children experience mental health crises or have, you know, mental health or behavioral concerns, a lot of parents want to know why is this happening, and what do I need to do, and to be able to be part of that conversation, to maybe partially or fully answer that question, or provide a roadmap to what needs to happen next, is what gives significant meaning to what I do, especially because it's not just me. I'm part of a multidisciplinary team. There's an attending or a PA or a nurse. There's sometimes we are able to get a pediatric psychiatrist to give us their opinion as to what do we do next with this patient. And when you're able again to go back to the family who came in a mental health crisis and was really looking for answers, and to be able to at least partially or fully answer the questions and provide a roadmap as to what do we need to do next, that provides meaning to me in the sense that you're able to somehow alleviate a little bit of that family's crisis in that moment. It's not perfect because the mental health system is not perfect. And there's not always an abundance of therapists or the type of therapy that you're looking for that would work for
Mhm.
that child. But like I said, if the multidisciplinary team approach to these cases really gives the family a roadmap to move forward.
Yes, and I agree. It based on what we're seeing in the larger society, clearly the system is not perfect. And you also mentioned that sometimes it depends on the school, you know, and the type of leadership or the type of social worker, which suggests some type, you know, suggests inadequacy in the system, and that there should be more consistency and more uniformity in order to, you know, give families the services that they need, so that it doesn't appear as if you are just pushing someone just along that corridor, regardless of the needs that they have, and still not addressing the need. But in terms of finding that meaning, yes, as you said, answer the questions, enter the what, why, how, when, I'm sure helps parents to kind of make sense of what they need to do next. So here's a question for you. Um, and I'm going to present you with a line of argument that, is generally out there, and let me hear what you think. What is your perception of this line?
Okay.
What is your perception of this line of argument? It says we need ears to hear, we need nose to breathe, and we need water to quench our thirst. And therefore, then, poverty is necessary for economic development. I think this question is appropriate because you mentioned that you're serving inner city families, and many of the families that you serve are struggling with various needs, mental health needs, medical needs, and I'm sure economic needs. Um, what do you think of this line of argument that many, even in the current atmosphere that we are, will say, well, there's some people that just cannot be helped. So if you're poor, poverty is a necessity. If you're, and it creates competition among us. What do you think about that? And in relation to the kind of work that you do as well.
Yeah. So poverty is a form of inequity, and there shouldn't be inequity. Uh, but we live in a society that values, we live in a country, I should say, that values capitalism.
Mm-hmm.
And when I think about that question, I automatically go to systems theories and think about just the interconnectedness of a family system, regardless of what that looks like within their environment. And what does that mean then for that family? I think about those interconnectedness of that, like I said, with that family system, the environment that they're in, so their community, the resources that that community has. And then I also look closer to that family system and think about their human capital.
Mm-hmm.
What capital do they have? I'm not talking about money. Like, how much money do they have in the bank account, or do they have like a trust fund, or I'm looking at their human capital.
Mm-hmm.
Does that Is that a two parent household that, would be able to raise the children? Is that just a one parent household? Because when we're talking about human capital, you're looking about time, you're looking about the ability to nurture the children in that household. You're looking at human capital also in the sense of educational attainment.
Mm-hmm.
And that requires time, not just money. It requires the ability to pursue something. Again, regardless of how much money you have, if you have to work two full-time jobs just to keep a roof over your head, you have very little human capital left over to
Mm-hmm.
pursue your aspirations and needs, because you obviously have to fulfill the basic necessities of your household in that time.
Mm-hmm.
So I, I don't believe that poverty is a necessity. I think that it is an unfortunate outcome of the model that we have embraced in this country of capitalism.
Mm-hmm.
Um, it's not equitable. It never has been. And, with the amount of wealth that this country possesses, and how much wealthier the top 1% is getting at the expense of everybody else,
Mm-hmm.
uh, there should be a way to figure out how do we support
Mm-hmm.
those working poor families, or those families that are in the lower economic branches, so that they can get a footing up from that. I don't think anybody deserves to be in poverty, because you're not just suffering financially. When you're in poverty, you're at risk for a lower life expectancy, a lower quality of life. You're at risk for more child abuse to happen in that household, more domestic violence, less not just your ability to earn less per year compared to maybe somebody else not in your same
Mhm.
socioeconomic branch, but also um, your ability is cut back on how far you get in the education field as well. And ultimately, if we really wanted to, I think there is a path, not an easy path, not a non-complicated one, that we would be able to eradicate poverty. Because again, it's not just that people don't have money, it's that people live less and enjoy life less because they are um, more burdened with things like food insecurity and other, maybe they're a higher risk for diabetes or other medical conditions just because they are poor.
Excellent point, Sandy, when you talk about what some of the outcome of poverty and what result in people based on what you observe in your emergency room. You mentioned food insecurity, and we're going to get to a question that kind of address that, but I still want you to talk about it here if you like. How does poverty can you expand more on how poverty affect people's ability to work, eat, and live healthy and practice healthy living, based on the explanation that you provided a while ago?
Yeah. So if we're looking at a household that um, is considered to be poor, or they're
Mhm,
living in poverty, or they're working poor, you know, um, besides their rent or their mortgage, that is a substantial portion of that takes up a substantial portion of their income. The other thing that people spend a lot of money on is food. And as we know, food is expensive,
mhm,
especially fresh fruits and vegetables, lean meats and seafood and things like that. Having a balanced diet is expensive. And when you really have to look at everything that a household has to cover,
mhm,
a lot of families don't have the ability to afford fresh fruits and vegetables, or maybe afford, to have a balanced diet. So you end up getting a lot more processed, shelf stable foods, more carbs. Um, and we know that things that are canned, they do have their benefits, but they also have a higher sodium content, high fat and sugar. And so maybe we don't buy apples because, those Honeycrisp apples are $2.99 a pound, but I can get this fruit cup mix,
mhm,
which is shelf stable, and pineapple, cherry, apple, little fruit cup mix. And my kids really like it. So that's how they get their fruit. But they also drink the syrup that's in there that has a lot of sugar and it's
right.
processed.
Mhm,
And you end up in a situation where, you have not a great diet. Then you end up in a further situation where you might live in an apartment, or you might live in an inner city block, inner city community where you don't have a lot of green space to run around, a lot of safe places for the kids to go and have some
mhm,
exercise and play. Maybe there's a lot of gun violence in your community and you'd rather keep kids inside after a while. Or you live in the northern part of the United States and it's winter for, it's cold outside for 5 months out of the year. So the and stay inside. So as we have a society that becomes more sedentary, where we don't move as much for a lot of
mhm,
factors, we don't have great, and you end up then having some kids that could potentially be overweight, or very much overweight. The medical terminology is obesity. And I hesitate to use that because I know that a lot of parents are uncomfortable with that term, and that's the
mhm,
current term that's used in the medical, and there's a lot of controversy about that. But when you have those factors playing in, and you end up then developing comorbidities like type 2 diabetes. You end up developing high cholesterol at a young age, or you end up developing um, other conditions, fatty liver. Then you know that if that's developing in a young child, that they're 9, 10, 11, 13, then you really wonder, what is that child's body going to look like when they're 30? What are they going to be dealing with at that age, you know? And you end up seeing lower um lower life expectancy,
Mhm.
and you end up also seeing that quality of life goes down. And you can tie all of that back to poverty and to their inability to have the same opportunity as everybody else to have a healthy lifestyle. Because again, foods and even a gym membership is not accessible to everybody. There's not a YMCA in every community. There's not a safe
Mhm.
place to go outside and play in a community. And all of these factors seem to interlock into really, putting many families at a disadvantage to live a healthy lifestyle and to be happy and healthy.
So yes, I guess we are agreeing then that poverty does breed a lot of diseases, and poverty does create a lot of restrictions. And if anything, it increases so many problems among people who are, you know, just simply fall within, being poor. And I agree with you. The capitalistic model is, for those who think poverty works better for an economic development, then they're the ones who agree with the capitalistic model of how society runs. You mentioned a lot about obesity and how uncomfortable parents are with that, with using that word or that term to describe what is happening. But it is, you said, and I agree, it's a medical term, and how how it's measured and how it's determined. It is said that the U.S. have one of the highest rates of obesity. And with the kind of program that you work, that I believe you'd work with weight management, or you're currently working in that area.
Yeah.
Um, what do you think about these TV shows that, you know, broadcast individuals going to great lengths to lose weight? Um, yes, people, do not have access to buying fresh foods and vegetables and so on. On these shows, it suggests that they are responsible for whatever they did to their body. Do you believe the solution to decrease obesity then is a personal effort, should be a personal responsibility? Or do you think it's a larger systemic issue, and it therefore should be a larger effort on society to help individuals? And that is in regards to what we see happening on TV, you're seeing happening in your emergency room. Um, who should be making more effort here? The individual or the system?
Yeah.
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 No, yeah, I think as a society, we we hold values of what is beautiful and what is ideal. And that is not necessarily shared all over the world. Um, you know, I think if you go back to movies from the 1930s, 40s, 50s, 60s, 70s, 80s, 90s, you see an evolution within this country as well as to what is beautiful and what is ideal. And the leading roles and maybe the expectations have unfortunately gone in the direction of skinnier, skinnier, skinnier. And when you grow up, especially because we see that this impacts women more than men to a certain extent, not that men don't have eating disorders or other uh, concerns about their weight and how much muscle mass they have and things like that as well. But we idealize a certain type of person, we idealize a certain body type. We fail to recognize as a society that we don't all have the same body types. And we tend to spin it as personal failure in the sense that if you are obese, it's because you're not putting the right type of food in your body, and you are obviously lazy because you don't exercise. And that type of simplistic view of it or judgment call is just not right by any means. We know that people who suffer with an increased body weight, have a complex of other things going on that are not easy to go through, that take some time. You know, we see kids that are very depressed on both ends of the spectrum. Either they overeat or they undereat. And we can see both sides of it with kids that have depression. We can see it with kids with anxiety as well. Some that overeat to cope with their anxiety, others that undereat and then can't eat because their stomach hurts with any form of food that goes in there. We see it with people who have autism or on the spectrum. And we see that, you know, when you're trying to parent a child who has autism and you really can't limit the types of foods, and or they only want to eat particular types of foods, like they'll only eat chicken fingers and French fries. That's it. That's their diet. They won't eat anything else. Um, so it's a systemic problem, and it's a problem that needs to be looked at individually and what would work for that person. And I don't think that resolving the problem of obesity should be that you have to look like this ideal type or you need to be like this to feel. Do patients come in thinking that? Yes, they do, because of the societal cues that are given to them through the media, through Facebook, through all these forms of external input from them, even some of their family members.
Yes.
But ultimately, you know, healthy does not mean skinny by no means. You know, you could still have really high cholesterol and be really skinny.
Good point. Excellent point. And so, share more about the weight management program that you're part of at Nemours. And, you know, by no way I'm suggesting that poverty, you know, is a result of, or obesity is a result of poverty. I'm sure, you know, you've seen people across all socioeconomic background that may, you know,
Yeah.
experience either, you know, being overweight or being underweight, as you explain. But let me hear your point of view of those individuals, the population that you serve, and whether or not we can. It's safe for us to say there is some correlation there with poverty and being overweight and not and being and not eating nutritious meals and so on. Where do you find those correlations based on the population that you serve?
Definitely a majority population that we see are minority. They're families of color. They're African American. They're Hispanic. They are typically a lower socioeconomic status. You see more rates of food insecurity, housing insecurity. You see more family disruption in the household, but it's not 100% by no means. We have, you know, families with that are intact, higher socioeconomic status, parents that are fully educated, have college degrees or more, have great jobs, and they have a child who is overweight or obese. And, you know, we never take out the genetic component that because there could be a genetic component to that, so that's never discarded. um, but unfortunately, um, it tends to be that these families are or minor or more these patients or come from minor families of who are minorities, and you end up seeing that the the complexity that that child's overweight or if they're considered obese at that point in time, um, is is linked to so many things, so many factors that come into place. And again, when you're looking at for example, families, immigrant families, where you see that let's say, for example, the family is from Mexico and now they're here, and the children are more Americanized than the parents, and the difference in the food culture from the parent to the child, and some of the differences there, and the real battles over food and whose food is cooked, and what foods are eaten at the household. There's just so many things. We try to look individually at each patient and their family system to better understand how can we help them live a healthier lifestyle. And we try to do a family centered approach, so we don't single out the child. We recognize that that child lives and breathes within that family system, and if there's going to be a change for that child, it's going to be a change for the family because it's ultimately good for everybody involved.
That's interest. That's a very interesting. So there's a you talk about the earlier on the family systems model where everything is interconnected. So now it plays out here even in terms of the treatment planning where the family must be involved in order for changes to be realized. You find that family members do cooperate when you create, suggest, make these goals for them and say this is how it's going to be done in order for them to realize change.
Many times, yes, families are engaged, but it really also has a lot to do with how much human capital does that family have left. And what I mean by that is if you're working with a stable family system where
Mhm.
there's stability there, and they're able to have the human capital, the time, and the energy to invest in making those lifestyle changes,
Mhm.
then they're invested with you that happen. But if you recognize early on that the system has other things, other competing demands going on,
Mhm.
for example, housing insecurity or parental mental health needs or some form of substance abuse in the household, domestic violence, if there's other competing demands,
Mhm.
we have to recognize the system. We have to try to address them because we know that the likelihood that those lifestyle changes will be made are less, and the retention rate is lower. And what I mean by retention rate is how often do they come back to see us so that we can adequately measure progress
Right.
and really adjust there as to what's working and what's not working.
Very, very interesting. And so you the model may be there. The foundation is set for families and how they can, make changes. However, as you mentioned, if you come back to the concept of human capital, if there's competing demands, if the human capitals are not in place to get the ball going, to get everybody on board, and to if they don't have the setting, then the environment to make all these changes, then the conflict and the problem will always be there. Excellent point, Sandy. I really do appreciate that. You also said something about, and hopefully I recall it correctly. You said skinny is not healthy. Is that what you said? So this brought me to, this brings me to my next question. Is that what you said?
Yeah, I said that. Doesn't mean
Okay.
you're healthy.
Right. So this brings me to my next question that, in terms of culture, you mentioned some, intergenerational conflict, I guess, over food. When you have a family that, first generation and second generation, having two different perceptions and concept about, what is happening around them. Of course, there's going to be that generational conflict. So in some culture, thinness is associated with poverty and hunger. Somebody's skinny, oh, they don't have enough to eat. And here you're mentioning that sometimes it's if anything, the food insecurity is what is causing or contributing to the obesity rate that we're having. So some people will kind of be, especially from different cultures, will be confused about that. So based on the population you serve, what is your view that if one is skinny, it is bad health, as you mentioned, and how does this definition of food insecurity, help you to make sense of that? And let me know if you want me to clarify that in terms of you're skinny, you're unhealthy. There's food insecurity that cause obesity, and you're just as unhealthy. So can it make sense of that argument for people who are watching and may be confused about these cultural perceptions?
Yeah. So I guess when we talk about food, talking about households that run out of food and they run out and they don't have any left, or they're worried that they're going to run out of food and don't have the financial means to afford more food. So
Mhm,
that would be like in a nutshell what I'm talking about when I'm talking about food insecurity.
mhm,
And there seems to be a relationship that's in the literature about how families that have children who are considered to be overweight or obese also tend to have food insecurity. You might be thinking, well, if you don't have enough food or you run out, how are you overweight?
right.
And what's happening is that as we go back to the types of foods that families are eating. So, if you think about a meal and just think about ballpark, how much would you spend on making dinner? Depending upon what you're making, you could spend anywhere between 20, 30 bucks, 40 bucks, depending on what you're making, right?
Mhm,
But if you have 3 kids and your rent is due tomorrow and your rent is 70% of what you make in a month, and you think about feeding 3 kids, and you go to McDonald's because you get something from the dollar menu, and how far can a dollar really go? Well, you can get 3 hamburgers, that's $3, and maybe one large fries, and that large fry dollars on the dollar menu, and right there that's $5, and you satisfied the hunger for 3 children in with that, with $5, which if you went to the grocery store isn't going to really get you far, not enough to feed all 3 kids and
mhm,
satisfy their hunger. So you end up seeing that where we go for food when you're food insecure tends up being choices that are higher in salt, higher in fat, higher in sugar content. And it's not that they're overeating so much, it could be that too,
mhm.
but it's the types of foods eating. So, if you're going to snack on some carrots, that's pretty healthy versus snacking on some Oreos. It's not as healthy.
Mhm.
But, we're talking about the choices of foods and we're talking about how much of that food we're eating. So if you have to stock up your pantry with canned items and pastas because you're going to get more bang for your buck, then you can see where the relationship with food insecurity and obesity starts to get created right there.
So previously you mentioned, with the impact of the pandemic, where kids are virtual, are in virtual schools. So for those who may, as you said, experience food insecurity, will rely on school for their meals. They're not getting that, and even though some school
Mm-hmm.
districts are reportedly trying to do their best to still provide the lunches. Transportation has become an issue for some parents to pick it up, or they're just not able to reach families because of the setting or the school district that they're in. So that also become an issue. I want you to talk about the skinny side though. Um, how is it that, even if children are not deliberately starving themselves, is it that they do not have enough food to eat? Is that what you do? And do you find children who are underweight in your in coming to see you in the emergency room? Families who
So
which
I think that, yeah, so I think that if I'm thinking the emergency setting, and if a child is underweight, so if they're babies, for example, and they're formula fed and they're failing to thrive or they're failing to gain weight,
Mhm,
we really look at their health at that moment to understand, make sure that they know how to make a bottle of formula. Because if reading the label can seem a little confusing because you want to make sure that you add, like when you're making a bottle, for example, you want to make sure that you put the water in the bottle first before you add the correct amount of formula, because if you do it backwards, for example, if you add the powdered formula in first and then the water, then you're making the formula too thick and not adding enough water,
hmm,
right? So that's going to contribute to poor weight gain when that's not mixed correctly, and it could potentially also choke your child, because
mhm,
it's too thick.
mhm,
Um, some some unfortunately, some families can't afford formula or don't qualify for WIC, or their WIC application is delayed and they can't get formula. Um, you could put too much water to too little formula. So you end up feeding the child more water than the actual formula. And you have underweight children in that sense. So really, you want to look at those things, not just the medical aspect of things. Do they have a metabolic condition or something going on where the child's not absorbing?
mhm,
So you look at that for kids who are underweight. I had mentioned earlier that we have a lot with eating disorders that come
mhm,
through the emergency department. Um, and in those situations, those kids are so underweight, so malnourished that they end up needing mostly to be medically admitted for, to make sure they don't have refeeding syndrome.
yeah,
And, you know, they're not, they're skinny as can be, and they're sure as heck not healthy. Some of them are to the point that their heart, they have, they're starting to have heart problems because they're even losing fat around the heart that protects the heart. And I'm not exactly sure the exact details of it, but it's pretty dangerous. You could die from that and have a heart
mhm,
attack, and very young age, and that's from how underweight the child is. But my social work colleague that works in adolescent medicine and deals a lot with eating disorders, her and I have crossed paths many times where we have patients go from one end of the spectrum to the next, where we might start off overweight and obese, and then we cross over to the eating disorder aspect of things, or we go from the eating disorder aspect of things and we cross right over. So we have a lot of overlap
mhm,
sometimes. And I think that with more pressure in people's social networks
mhm,
to look a certain way when you're creating content for the internet, for your media, or whatever you're doing, you end up just having a lot more pressure to be a certain way, to look a certain way. And you end up having kids that, go to those extremes of developing an eating disorder. But again, it's a lot in an emergency department that you can see. But yeah, like I said, skinny doesn't always mean that you're healthy, and it doesn't mean that you're skinny because you're doing it in a healthy way as
mhm.
well, especially when kids start to lose weight.
So I agree with the point of the kind of pressure that kids experience, especially I know the literature does suggest, especially for the adolescent girls, that's when, if anything, so possibly that's when you start seeing that crossover, um, um, maybe at their younger age, they were a little obese, and then by the time they start peaking to their, um, you know, teenage years, that's when they started being more self-conscious or being pressured by their peers to look a certain way, and therefore started edging towards the skinny side. So very interesting information.
Yeah.
So many areas there to explore, because I could also ask you questions on, whether or not that falls under child abuse and whether DCPP might become involved in those cases. But that's so many complex areas that we have to get into another time, because here I want to ask you about, especially this is up your alley, in terms of health literacy. I believe you did a research on this one. Um, how do you go about educating parents then? Because with so much knowledge to out there to provide to parents, and how to help their children, creating this awareness for them. Yes, the resources are not there to make this drastic or immediate change, or I mean, but there can be some short-term goals, long-term goals, and changes can be realized. What is the meaning of health literacy for anybody who's trying to make sense of it, and how do you go about helping your patient make sense of the meaning of what they're going through, and to realize and to,
Sure. So I think probably the simplest way that I could talk about health literacy is a person's ability to understand the medical information that's provided to them, and to know how to act, or what it is that they need to do with that medical information that they're provided. So,
Mhm,
for example, if take your child into to see a doctor and they tell you you're pre-diabetic, do you understand what that means? And if the doctor explains it to you with terminology that you don't understand, because parent, you might not have gone to medical school, and if you don't understand how the body works, so how does the body produce insulin? Where does the body produce insulin? How does the body use it when you eat? Or what does that work with? How does that work in your body? And then what do you need to do to prevent it from then developing? Or are you even sure that what the doctor is telling you, if you're pre-diabetic, that you could then go into being diabetic? And what's the difference between type 1 and type 2? So again, health literacy really looks at a person's ability to understand the medical information they were provided, and know how to act on that information. So what is it that you do next?
mhm,
So again, going back to that example of a parent who's being told that their child is pre-diabetic, do they understand what pre-diabetic means, and do they understand moving forward what can they do to prevent the child from becoming type 1 or type 2 diabetic? You
mhm,
know, and then I think that because we have an interpreter and talk to the family, people think that that means that the family understands. Or let's say we don't have an interpreter, they speak English fluently. Because we spent 5 minutes talking about the condition and pulled out a chart and showed the growth curve and where the child is above the growth curve for weight, and their BMI is this percentile of this. If that parent genuinely doesn't understand what's going on, and doesn't have the confidence, or maybe doesn't feel that they can ask the provider, what does that mean? Or can you explain that to me in a way that I could understand it? Then how are they going to effectively leave that office and know what to do with that information? Or worst of all, how are they going to follow up with you? Because they might never come back to you, because, they didn't understand what was going on. And if they didn't understand, they might just be like, well, he looks healthy. He'll probably just grow out of it. I'm not gonna worry about it. So what we try to do in many settings is we try, or I should say, I try to really assess their health literacy. There are a couple of tools um, that are able to give you a quick sense of where that patient, where that family stands. So, for example, Pfizer has a free open tool that anybody could use. It's validated in English and in Spanish. It's called the New Vital Sign. And it's a quick 5-minute question where a parent can read off of a nutrition label and answer 5 quick questions based on their ability to interpret an ice cream nutrition label. And you get a good sense of their numeracy skills. You get a good sense of their reading skills. You get a good sense of some of those components that go into health literacy. And, if you do what social workers do, which is you engage the family and build trust, you have a good way of helping them gain their health literacy, of helping them improve their health literacy. Because one, they're more likely to ask you questions if they feel they can trust you.
Mhm.
And they're also more likely to come back and follow up with you. And you then have an opportunity to clarify something that maybe wasn't clear the first time, to provide further education, and to reinforce what has been done right and maybe some areas that could be improved upon. And when we do that, we ultimately can see better health outcomes for that particular.
Very good, Dr. Ramirez. I appreciate that, the way that you define it and the health literacy and the examples that you provide. It's excellent. And it brings us back to the point that you make in the beginning, when social workers or school administrators are not doing their work to inform, to educate, to create this awareness, and to give that sense of hope and trust that is needed in the field of social work. And you're seeing how it just trickle down and affect every aspect of a family's life, especially a family who depends on the system, who depend on others to kind of
Yeah.
help them to navigate life. So we're almost out of time, but I still want to ask you, um, based on all the things that you shared and such very, very interesting information and very good insight. What should we take away from what you're telling us about your work? What you're telling us about your perception of what is happening in terms of the type of work that you do with families, especially on the topic of obesity, on the topic of poverty and health literacy? What is it that you wanted? What is your takeaway?
I think my takeaway overall is that they might sound like cumbersome or complex problems that we face as a society, but I think that we can definitely reframe those to be opportunities to learn and grow, because we can improve from them. We can grow from them. And it doesn't mean that we have to solve them 100%. It doesn't mean that every family is going to be, perfect.
Mhm.
It just means that it's an opportunity to. And I think as a society, we have an opportunity to grow. And as individuals and family systems, we have an opportunity to grow. I don't know if we'll ever be able to achieve perfection or resolve every single social problem that exists out there. We might resolve some and then create other new ones, but they're opportunities. And I hope that we can have those discussions further and, make some improvements. There's always a chance to improve. And that's the beauty of being humans. We're always looking for the next thing to do.
And that is such an excellent note to end. And this is really been very informative for me as well. And it kind of allow me to just make sense of someone who is in need of help, or in some of the situations that you describe, and what they may encounter, and what we as social workers, or anyone in the medical field, anyone in the mental health field, school district, community settings should do to help. Dr. Ramirez, it's been such a pleasure talking to you. And there's so much areas that you raised that I'm hoping that we can talk more um, on these very interesting life factors. Thank you again.
Thank you.